Welcome to Heart Failure Unfiltered. My name is Nick Hartshorne-Evans and I'm the founder and CEO of the Pumping Marvellous Foundation, the UK's heart failure charity. Today, we will be discussing learnings from our marvellous Masterclass events where we educated and worked with over 170 non-specialists to increase their awareness, upskill their knowledge specific to heart failure in primary care. This is the fourth of a series of 4 podcasts, or the final podcast, about heart failure and why the simplest ideas often save the most lives. This podcast asks one question over and over again. When knowledge becomes action, how the marvellous Masterclass is changing heart failure care. Because if we don't enable our workforce to be better at detecting the symptoms, diagnosing and managing heart failure, this has a direct impact on patients. So what stands out about the marvellous Masterclasses is they are not just education events. They sit in a space between patient voice, professional education, system improvement and behaviour change. A lot of heart failure education focuses heavily on guidelines and pathways. What is different about this approach is that we bring the attendees repeatedly back to the missed moment, the overlooked symptom, the human impact of delay, and the role of primary care in changing outcomes before this crisis happens. This gives our podcasts real strength because they become more than an event. They become conversations about why recognition, confidence, listening, and action matters in real life. These are the reoccurring themes across the marvellous Masterclass programs. Spot it early, listen differently, simple is safer, patients remember moments, primary care changes outcomes. The system often misses what patients are trying to say. That consistency is what makes campaigns like our Beat HF and the Masterclass feel connected to reality. If you've just been diagnosed with heart failure, it can feel overwhelming. You may have more questions than answers. The Pumping Marvellous Foundation helps people make sense of heart failure with clear, patient-friendly information and supportive resources designed by patients themselves. Understanding your condition is the first step towards living with it. Search Pumping Marvellous Foundation and start your journey with the support you deserve. When I was diagnosed with heart failure, what I needed most was clear information and reassurance. That's why we created the Pumping Marvellous Foundation. Every day, we help people understand their condition and feel less alone. Just £5 can help us reach the next patient who needs that support. £5 may not change your day, but it could change somebody else's. Visit pumpingmarvellous.org and help support patients today. Today, we're at the Liverpool podcast studios. I bet you hadn't guessed that. And if you've seen our podcast before, then this is our home of podcasting, which is great. It's just off the waterfront in Liverpool. So today I've got some amazing guests. Corinne, do you want to introduce yourself?
Hi, I'm Corinne. I'm a patient educator with Pumping Marvellous and I'm on the board of trustees as well. And I was diagnosed with heart failure about 5 years ago.
Thanks.
Hi, I'm Dr. Sue Kemsley, a GP, GPSI in Cardiology, and I also work as clinical leads for Health Innovation North West Coast, working with Sarah, and clinical lead for the North West Coast Cardiac Network.
Thank you.
Hi, I'm Sarah Coburn. I'm a Senior Programme Manager at Health Innovation North West Coast. I'm a clinician by background. I was a physio many years ago and now work with the North West Coast HIN to a 2-year programme in heart failure.
Just give us a little quickie HIN.
Okay.
Health Innovation Network.
Yeah, sorry.
What exactly does that mean?
So basically we're the NHS branch that deals with innovation in healthcare. And our role really is to connect the system with innovations. And I think a lot of people always think that's, digital and tech, and which of course it is, but it's also around making pathways clearer, easier to understand, more efficient. It can be around public awareness, lots of different things.
Mm-hmm.
But yeah, we work in that field of bringing innovation into healthcare systems.
So how many HINs are there?
Oh, there's 15.
Okay, and where
England.
Does your HIN start, finish, left and right?
Yeah. So mine is in the North West Coast patch, which is a footprint which covers Lancashire, South Cumbria, and Cheshire and Merseyside systems.
That's a pretty large population then.
It's big,
Very diverse. Great to do testing in because you have so many different socioeconomic types.
Yeah, real mixed demographic and a mixed population spread as well. So we have some really rural areas, coastal, very deprived areas. If you think about Blackpool being sort of the most deprived, one of the most deprived or the most deprived area in the country, a real mixed demographic
big
in
cities.
terms of big cities, big university cities, and then some really, small populations spread out in, if you think about South Cumbria and their population geographical challenges for healthcare systems. So it is a real mixed bag, and a mixed population base, some very deprived areas, some very wealthy areas as well.
So Sue, why was it important for a patient-led charity, or why did Health Innovation North West Coast pick the Pumping Marvellous Foundation to partner with to improve focus on primary care heart failure education? What do you think?
I mean, I guess you've done it before, previously. So we just took what you did before in terms of your masterclasses, and we adapted it, I guess, for our region.
Mm-hmm.
Why did we do education? Education is a vital step in implementing and adopting any new innovation or technology. You can't advance unless your workforce understands how to identify and manage a condition.
So, Sarah.
Yep.
Why did you were the program
manager? Yeah.
Manager.
Whatever that means.
Why did you sort of light the spark?
Well,
because it's a big, innovation could be seen as, we had a lot of involvement in this.
Yeah.
That's quite unique.
It is quite unique, but our partnership, our values and our ambitions in heart failure aligned totally. So I think it was very obvious when we started talking, Nick, and we understood more about what the charity does. Pumping Marvellous are an innovator. They're changing the way people perceive heart failure. They're looking at ways to do things differently. That's all innovation. Even the fact of, your BEAT acronym, making it easier for people to understand where to access diagnostic tests. This is all shifts in pathways.
Big signs
that are lit up. Ooh, innovative. So I think, and also a different way to connect with the public. So oftentimes, in healthcare, the public only know about something when there's a national campaign that goes out. Maybe they see something on a billboard, maybe they see something on the tube. But as a charity, you're really trying to connect with the public in different ways as well. Podcasts, videos, you are doing big advertising campaigns and successfully as well, but bringing in patient voice as well. So I think nothing connects with someone more than someone that's living that experience. And I think that's something we didn't really find elsewhere either. So
Corinne, what do you think you were walking into then when I invited you to come along and be a patient expert? What did you think?
What I hoped was that I was going to be sort of being able to sort of maybe break some stereotypes. I think that...
Sorry, say that again.
Break some stereotypes.
Okay, yeah.
Yeah, because I think that sometimes there's people perceive that there's a type of person that has either a heart condition or particularly heart failure. And I think myself and the other people who, as patients there on the day, we were able to sort of, use our stories to sort of break those stereotypes and, different ages, demographics or, whatever it does, it breaks down those sort of thoughts really. And that people, heart failure affects people for different reasons and it affects all different types of people.
The Pumping Marvellous Foundation was created by patients who understand how confusing heart failure can be. Today, we continue to make sure patient voices are heard and patient needs are understood. Your donation helps us continue advocating for better awareness, better support, and better care. If you'd like to stand with patients living with heart failure, visit pumpingmarvellous.org and support our work. One of the reoccurring things that I heard over the two events, about 170 people, was confidence. So what happens when systems invest in improving confidence and capability closer to home, in other words, in their workplace? Because we wanted them to leave, have a great evening, wake up in the morning and think differently.
Yeah.
Where's the benefit in that, do you think? It's quite a difficult question maybe to answer.
It is. I mean, it's a huge question. When I trained, I know this is slightly different, but when I trained as a GPSI in cardiology, and just bearing in mind I did sort of 3.5 years master's level stuff, so it's wasn't a one-off. But when I trained as a GPSI in cardiology, and I go back into general practice and try and do my day job, you inadvertently create somebody that doesn't fit in.
Mm-hmm.
So there are disadvantages. So I go back to my practice, and all of a sudden, nobody likes what I do because I do things differently and I challenge what's going on and I try and educate everybody. So you can inadvertently create this clinical animal that doesn't quite work in the system. On the other hand, it needs to happen because the knowledge base is just not out there. So, when I did the training, I've always been interested in cardiology. I was in it up to my neck when I was a junior doctor. It's never been any different. So I suppose I've always been a slightly different GP, I guess. But
it's surprising you say that.
Are you?
Because I think you're correct, because there aren't that many GPs who specialise in cardiology.
No.
They're quite few and far between.
I think for anyone who's not done cardiology, they're very scared of it. And I think,
Glad you said that.
I think when so I've been trying to upskill my practice for years, even before I did the formal training. I did mad ECG interpretation training in the early 2000s, because I think that an ESC cardiology conference, they did a survey of cardiologists and how much formal training they had on ECG interpretation. And it was something like only 0.5% of them had formal training on ECG interpretation. So I decided I was going to do it properly. So that's what I'm like. So even then, I was trying to upskill my practice. And it's just so difficult to do, because unless they really take themselves off and do the whole shaboodle, it's very hard for them to have the right in-depth knowledge to understand and manage the problems. So I know a lot of the feedback from the course has been, we want more education, we want it simple, we want pathways. And I think all of that really does help. I don't know if I'm going off on a tangent.
No, you carry on.
And I think it really, really does help. But I think the difficulty that we're facing when we start to educate is it's never quite enough in the system that we've got.
And also it's the style of delivery of that education as well. Because when I was looking at the sort of the basic analysis that we've done, it was how we delivered it.
Yeah.
It wasn't just like PowerPoint. There was something else to it that they wanted.
Well, different people learn in different ways, don't they? And need different formats. And I think, it's a big subject, and to hope to teach everything on heart failure, even just in one day, is overly ambitious. And I think, you need to keep revisiting it and reinforcing it. And I think learning from patients, from patient stories, from cases, from people that they see with heart failure, that then helps to reinforce what you do next. But, I think if we can't aim to turn every primary care clinician into a heart failure specialist.
Right, this is about aggregating.
Yeah. So it's trying to upskill enough to be able to then look at sort of pathway redesign and how I think we'll probably move on to that
interesting.
Next.
They always talk about, so in sales, 20% to tipping point. Right. And it's about converting 20% of people, and then it just tips over. And I think that's probably very, very similar with heart failure. We're constantly trying to educate and trying to understand what people want to know and how people learn, and validating that learning. And we will get there. It just takes some time because it's such a big thing to move. So here we go. We will get to that. The question has to be, how does this support workforce transformation in ICB's integrated care boards? Because these are the organisations that will have, I believe, the funding to drive programmes forward. So do you want me to repeat that? You're all right.
Workforce transformation.
Yeah, sure.
Got it. That's a biggie. But I think oftentimes we think of the NHS as very stretched, which it is, with clinicians that are doing too much, which is true.
Yeah.
But sometimes we don't help that either. So, we have clinicians that have patients going for one test, then coming back to them, then going for another test, then coming back to them, then coming for another test whilst they work out what's happening with the patient. And oftentimes that is creating multiple steps in a pathway, which potentially we could reduce down. So if people were thinking along the same line, so if we say, patient in front of you could be this, could be this, could be this, but we're not going to miss out heart failure here because we're going to be thinking about what we've just learnt in that masterclass and thinking about, actually, should we do this test now? And we can also send them for their other tests, but we know there's a test that they can do straight away, gives us a clear indication of whether we think this is going to be heart failure or not. And this starts to build into a picture of how we can redesign pathways to deal with that. But workforce transformation in terms of education, I think it brings it back into the workplace, because once you've educated people, you can start to think about, actually, does it need to be a doctor that sees this patient? Or is the pharmacist skilled enough to do that? Is the ACP skilled enough to do that? Actually, who's picking up this education elsewhere? So we had people join our masterclasses from not heart failure backgrounds. We have respiratory nurses coming in, diabetes teams coming in, because they also see these patients out there, but they're being upskilled now to think of other conditions. And that's when we start to work better as a system, more connected. We're very keen on very siloed working in the NHS, that we have, clinicians skilled in heart failure that deal with a heart failure pathway that's been written. We have clinicians working in respiratory that has a respiratory pathway that's been written, diabetes, etc. But when we start to join that together, that's when we start to think about actually the workforce as a whole, and how can we better connect that, and how can we stop that duplication of effort.
I think we have to be careful that we don't dilute stuff.
Of course.
So like a diagnosis of heart failure, the actual diagnosis, when you're putting together the NT-proBNP, the blood results, everything else, the echo, is relatively complex to make the right diagnosis. And that should be, GPSI type SU or consultant cardiologist. I don't think we dilute that, but I think there's opportunities around the diagnosis, the recognition, to get people into that system. And when they come out of that system, we know how to manage them as well. And,
better manage them.
Yeah, and the Manchester, very quickly, but the Manchester 2018 Marvellous Mentors, which it was called, was about trying to upskill the whole of the GM footprints, primary care teams and community teams. Because I said to the deputy chief nurse on a really rainy, I can see the wipers going now, coming back from Preston in the rain. And I said, right, I want you to give us £2 million and we'll recruit, train and develop and make sure that there's enough heart failure nurses across each of the boroughs, which there wasn't at that point in time. There was, and it was delivered differently. So there was community, there was integrated care, there was just acute. For these heart failure nurses, and she said, well, what about this? And that's where Marvellous Mentors Masterclass came from, which is me being cheeky and asked for a couple of million.
That doesn't surprise me, Nick.
Yeah, do you think that ICBs should prioritise heart failure education and awareness? Do you think they should?
Well, as we know, we've got an ageing population. We've got pressures that aren't going to go away. The prevalence of heart failure is going up. Mm-hmm. So it begs the question, why wouldn't we, really? And obviously, within a system, there's many priorities and many areas of focus that all ICSs, all ICBs have to deal with and try and, work through at a population level what gives the most bang for their buck and where they invest their money. But we do know that heart failure causes sort of a disproportionate amount of admissions, or a lot of admissions into hospital. If we don't manage heart failure properly and effectively, then those hospital stays are longer than they should be or could be. We know that there's priorities in terms of, within 10-year plans of moving resources or moving that pathway to the left. And by that, I mean, we've got commitments to move from hospital into the community. So establishing good understanding, education and awareness within primary care and community settings is the direction of travel. And so I guess why wouldn't we invest in that? But it's one of many, I guess, areas that we always have to strive to work through.
But Sue, putting your leadership hat on, yeah? What do you think success would look like, and what would the learnings be if it was embedded right across an ICS or an ICB?
I mean, I think you have to bear in mind the number of appointments attended by people with long-term conditions is huge. And if we continue to do what we're doing now with the rate of increase of all the chronic diseases, we're just going to fall over. We're already falling over as a system. So what would good look like? I think if we did have effective education on heart failure, dovetailed with all those risk factors and long-term conditions and managing people holistically, then what we could then see is massive savings, both in time, money, and, well, patient time and numbers of years lived and numbers of years lived well. So, and you then, you improve employment, you improve the social care system. I think the impact is potentially massive.
So, Corinne, do you think you made a difference when you attended the 2 events in Preston and Everton?
Yeah, I mean, it's easy to sort of just say yes, and of course I did. But
maybe phrase it differently.
Yeah, I think we made a difference. I think with the patients,
the collective we.
Yeah, the collective we, the patients that were there, the patient educators that were there. I think we definitely did.
What could we do differently and better?
I don't know. I mean, I think it would be. I think my worry is. We all, well, not all actually, but at least 2 of us have a story that sort of feels quite negative towards primary care. And if we're not careful, I feel very wary of standing there or sitting there or whatever, and sort of saying and bad mouthing, because that's not constructive. And I think that.
Do you feel were you very conscious of that?
Yeah, very much so. And I feel sometimes very conscious of not wanting to say certain things because I don't feel that it's a one person. It's not a one person, or within what with what happened with my experience, it wasn't one person that it was at fault. It was a system situation, in my opinion. And I would hate any one person to sort of come away thinking I've done something wrong here, because they didn't. It was just, as a friend of mine would say, it was just a happening. It just happened. But we need to make sure it improves, and it's making sure that we don't. That we're not negative and we're positive and we empower people and we help people, and that can sometimes be a bit tricky from a patient. And we have responsibilities too as a patient to make sure we're listening and that we're receptive to what being spoken to as well.
Communication's both ways,
absolutely,
yeah. And there's a responsibility from the person being treated or being seen by a healthcare professional, and that should be a contract.
Yeah.
And that goes all the way through managing that long-term condition and being, being aware of the things that actually make a difference and the things that you can do.
It's time for a marvellous myth buster, busting the myths around heart failure. Myth: heart failure and heart attack are the same thing.
Truth: a heart attack happens when blood supply to part of the heart is blocked. Heart failure is when the heart struggles to pump effectively. So I've got a final question for Sue and Sarah. What practical actions can ICBs take next week based off, maybe the wrong question, this one, based off, what they may have seen or the report that we'll produce? What's the takeaways and what do you think they should implement?
I mean, of course, realistically, it's going to depend on national and regional priorities. I think one concern I have is clinical leadership within ICBs, because many of the clinicians don't have heart failure training. So how do ICBs understand that heart failure should be a priority when actually the only clinical voices in there don't actually have that training? So that's one of my concerns. I think ICBs need to continue to work with clinical networks, and we're all hoping that will continue to happen. I think I'm lucky in my position that I've got one foot in the clinical network, one foot in health innovation, and one foot in primary care, as well as being a GPSI in cardiology. So I think if we can keep the conversations going with the ICB, to look at pathway redesign, look at workforce capabilities assessment, particularly in the current move to integrated neighbourhood teams, which is the one thing that gives me hope for the future. I think we could get there.
So, Sarah,
Yeah.
firstly, I'd like to thank you for your vision. Yeah.
Oh, thank you.
Well, no, you approached me, and because I thought, COVID smashed the program, but you came to us with Michael. Thank you very much for your leadership as well, Sue.
Okay.
What can they do? What can ICBs take away from this, and what would you expect? What would you like them to do?
I mean, I think the ICBs actually have a really good opportunity in this introduction, as Sue said, of neighbourhood models, of really starting to make a shift into pathways which would be better for patients. So I would like them to think, obviously we always talk about funding and finances being in the right place so those patients get the right experience. And I think there's an opportunity to do that differently. And at a population level, it kind of makes sense with heart failure. It is causing the multiple appointment situation. It is causing admissions to hospital where the first diagnosis is made, which, hopefully in Katie's case or in Corinne's case, that could have been avoided potentially. And so that's extra pressure within a system. So for me, bringing heart failure to the forefront of people's minds, oftentimes in cardiovascular world, which is, sort of always a priority area. And we look at blood pressure, atrial fibrillation and cholesterol as key areas of focus. But heart failure has never been as focused upon. But because of the implications of heart failure and the fact that we do have a population that hasn't been diagnosed yet, because we know the prevalence is much higher than we're seeing come through in our diagnosed patients on GP registers. And the fact that population is only going to get bigger. So it makes sense to have a look at heart failure and give it the focus and priority that it deserves, really.
So, go on. Sorry.
No, I was going to ask.
So here's a little thought. If the groundswell could influence the leadership, so not the decision makers at the strategic level, but at the tactical delivery level, where what we're talking about, the teams operate at in communities, in primary care, outside of the acute hospital system. I think that is quite an interesting model, rather than constantly trying to influence the people who make strategic financial decisions. So if every primary care team became more confident in heart failure care, what could that mean for patients in the NHS? And I'm going to leave that with our listeners around the world. And this has been Heart Failure Unfiltered. And thank you very much indeed for joining me.
Thank you.
Thank you.